Hello everyone. Today we are going to discuss a topic which is vertical incomitant horizontal heterophoria, simply which means that these are your horizontal heterophorias or heterotropia which are inconcomitant vertically. So if you see this deviation, what will happen? The amount of deviation will differ in up and down gaze. So these are your esotropias or exotropias which will differ depending upon the gazes. So it is an inconcomitant squint basically. So let's see what are these and what are the different classifications. So in concomitant strabismus, when I say, as I said earlier, that whenever there is your different amount of deviation in different gazes which is manifest, that is what is called as your inconcomitant deviation. So in that you will see that when you ask the patient to look in primary gaze, the amount of deviation would be different, but as you ask the patient to look into different gazes, the amount of deviation will start differing from the original one. Incompetent strabismus, when we say, so in this it could be etiologically classified with the help of your three different categories. So either it could be a vertically incompetent horizontal heterophoria, or it could be a paralytic strabismus, or either it could be a restrictive ocular motility defect. So when we say the vertically incompetent horizontal heterophoria, which we are going to discuss in this, we can find different patterns. So these are named because of the pattern which it shows. So these are different patterns seen during your deviation. So either it could be an A pattern, either it could be a V pattern, either it could be your X pattern, or either it could be your Y pattern. There is also one pattern which is called as your lambda pattern, which is an inverted Y. Whereas when we say the paralytic squint, so paralytic squint is basically paralysis of your muscles. So either it could be your paralytic esotropia, which is resulting because of the lateral rectus paralysis or paresis, or either the divergence paralysis, the diverging muscle, which is basically your lateral rectus. So if that is paralyzed, that could lead to your paralytic esotropia, or paralytic exotropia, which could be either because of your medial rectus paresis, which is isolated. So there is two types. So either it could be a complete third nerve palsy, or only a part of third nerve which is supplying to the medial rectus that is getting paralyzed. So your isolated medial rectus palsy, or either it could be a complete third nerve paralysis, or it could be only the paralysis of convergence. So sometimes what happens, the convergence center or the nucleus which is responsible for the convergence, that is getting affected, and only the particular part of convergence is getting affected and getting paralyzed. So next is your paralytic vertical deviation. So paralytic vertical deviation, when we say, it could be either because of your superior oblique palsy, either it could be because of inferior oblique palsy, or superior rectus or inferior rectus, or part of complete third nerve palsy. So we all know that the superior and inferior rectus, again, they are supplied by your third nerve, also the inferior oblique. So a part of it, when it gets affected, so that could also lead to your vertical deviation. Or either it could be because of supranuclear lesions, which is your double elevator and double depressor palsy. So double elevator means the elevator muscles of the same eye are getting affected, that is your superior rectus and inferior oblique, and double depressor is your inferior rectus and superior oblique. So coming on to the next type, that is your restrictive ocular motility defect. So in that, what it is, either it could be because of the misdirected muscle force, or due to the mechanical restriction. So when we say the term misdirected muscle force, that is either the innervation is incorrect, or either the insertion of the muscle is not proper, or either because of some structural abnormality, the muscle force which is acting. We all know that these inferior and superior rectus and your obliques are coming at an angle. So if this angle is not proper due to any structural or physiological aspect, that could lead to a misdirected force, which could lead to overaction or underaction. Your restrictive motility, again, it is due to the mechanical restriction, which could be because of tight extraocular muscle, structural adhesion, or orbital mass. So when we say the term your tight extraocular muscle, so these are generally because of your different syndromes which are present, or either it could be because of your congenital cranial dysnervation disorder. So what happens is that like for example, Duane's retraction syndrome, that is one of the example. So in tight extraocular muscle you can have thyroid ophthalmopathy, or either it could be your entrapped inferior rectus. What happens when there is an injury to your orbit? So if the floor has damaged very badly or in a blowout fracture, so what happened that your inferior rectus can get entrapped into that fracture, and that could lead to your restriction, or either it could be strabismus fixus. Okay, so these are the different types where tight extraocular muscle is one of the reasons, or it could be because of structural adhesion, which could be because of your fat adherence after a strabismus surgery or a RD surgery, or a congenital fibrotic band, or your acquired Brown syndrome due to your inflammation, your scarring, or either the conjunctival or Tennell's capsule scarring. So these are the reason for structural adhesion. And when we come on to orbital mass lesion, so orbital mass lesion, when we say, it could be because of the orbital tumors or the glaucoma bleb. So we all know that there are bleb which is made to control the IOP in a case of severe glaucoma. So if that bleb is obstructing the globe to move in a particular direction, that can also lead to your vertically inconcomitant strabismus. Coming on to your vertically incomitant horizontal heterophoria, so these are your A pattern, V pattern, X pattern and Y pattern. These are the patterns which we have discussed into our PPT. So let's see what are these patterns. So when we say the term A pattern squint, so A pattern squint, if you see in this diagram, it is very clearly showing that there is an A pattern which is made. A pattern means, when I say the term A pattern esotropia, so the point of A is upward. So what happens, the esotropia will be more in up gaze, it would be lesser compared to up gaze in your primary position, and in down gaze it would be almost no or less than your primary gaze. So what happens, as you come the down gaze, the amount of your esotropia will decrease, and as you go towards up gaze, your amount of esotropia will increase in an A pattern esotropia. And in A pattern exotropia, what happens is that when you look upwards, exotropia, as we say exotropia, so the point is upward and more separation is downwards. So what happens, in up gaze there is almost no or least exotropia, and as you move downwards the exotropia will increase. So if you see here, you make an A, so closer means esotropia, further means exotropia. So in A pattern esotropia, up gaze you have more deviation, down gaze you have the least, whereas in A pattern exotropia, down gaze you have the most deviation, whereas in up gaze you have the least amount of deviation. Coming on to V pattern exotropia, so in V pattern exotropia, again you make the pattern V. So if you make the V, your V pattern exotropia will show more deviation in up gaze, lesser in the primary gaze, and least in your down gaze. Whereas when you will see V pattern esotropia, so for a V, the pointed part is downward, so esotropia will be more in the down gaze when compared to your up gaze, least in up gaze and more in down gaze. So this is V pattern exotropia, and this is V pattern esotropia. Coming on to your Y and lambda pattern, so Y and lambda are just inverse of each other. So if you just simply see the Y, what will happen, that it is more separated in up gaze and least in down gaze. So this is an example of your Y pattern. So if you see, when we ask the patient to look in up gaze, there is more separation of exotropia. So there is only exotropia seen in these cases, there is no esotropia. So when the patient looks up gaze, there is more deviation, but in the primary and in the down gaze, the patient will have your least deviation. Whereas in your lambda pattern, what happens, when you ask the patient to look in down gaze, the deviation would be more, whereas in up gaze the deviation would be least. So this is only exotropia which is seen in Y and lambda pattern. Previously we saw that A and V pattern have both ESO as well as exo. Okay, so these are the different patterns. This is what is called as X pattern squint. So in X pattern squint, if you see, the deviation is more in up gaze and down gaze, whereas it is lesser in primary gaze. So what will happen in primary gaze, whatever deviation you will get, in up and down gaze, both the gazes it will increase compared to your primary gaze. So that is what is called as your X pattern squint. So these patients essentially have no deviation or a very small deviation in primary gaze, but it has a very significant exotropia present in up gaze and down gaze. So that's why it is called as an X pattern squint. So if you make a simple diagram, if you see this X at this point, which is primary position, you will have no or less squint, but up gaze and down gaze, as both the eyes are getting separated, that is exotropia. Understood? So let's go with the next point. So etiologically, it is basically your four factors because of which it can be caused. So it could be either oblique muscle dysfunction, or it could be because of your horizontal rectus muscle dysfunction, vertical rectus muscle dysfunction, or either because of the orbital factors. So when we say the term oblique muscle dysfunction, this is either your inferior oblique overaction, which will result to a V pattern squint, whereas your superior oblique overaction generally has A pattern squint. So whenever there will be a superior oblique overaction, so that will lead to an A pattern, whereas inferior oblique will lead to a V pattern squint. So these are generally how you see because of oblique muscle dysfunction. Whereas in horizontal muscle dysfunction, horizontal rectus muscle dysfunction, what we see is A esotropia is generally because of an underacting lateral rectus. So if there is an A esotropia, that is because of underacting lateral rectus. A exotropia is basically because of underacting medial recti. So in ESO it will be the underacting lateral, in A exo it will be the underacting medial. Okay, so when we say the V will be always overacting. A is always underacting, V is always overacting. So V esotropia will be overacting medial recti, and V exotropia is overacting lateral recti. So these are some of the synonyms which are generally used. Whereas when we say the vertical muscle vertical rectus dysfunction, so it is seen that however this concept was not very much popular. So your vertical rectus, generally the inferior and superior rectus, whenever they are having any overaction or underaction, that could also lead to your AV pattern, but no such conclusive point have been discussed in literatures that which muscle exactly causes which type. Finally, coming on to your orbital factors. So in orbital factor, generally patient with Elpert and your Clausen syndrome show a V pattern exotropia, so or an esotropia. So generally whenever these patients will come with A or V pattern, so these patients are generally having your what we say, the patients with your Elpert and Clausen will always show you V pattern type of squint. That V pattern could be either an exotropia or an esotropia. So that is one of the points of orbital factors. Also patient having your upward or downward slanting of the palpebral fissure may show AV pattern squint. So your palpebral fissure, if there is a slanting present, that could also lead to your AV pattern squint. Coming on to the point of clinical features. Now clinical features are very important here to understand. So what happens here, the patient will have a transient diplopia. As we saw in different types of your squint, there were some squint in which there was one point at which there is least or minimal deviation or less amount of squint, so because of which the patient will have a transient diplopia. Whenever the patient sees through a gaze where there is a least amount of squint, so he will not have any diplopia, but the moment he changes his gaze to the maximum deviation, he will start having a diplopia. So the patient will say that at a particular gaze, like for example if it is a pattern esotropia, so the patient will say whenever he looks at up gaze he has more deviation. Or let's say if there is a V pattern esotropia, he will say whenever he reads he sees double, but when he's looking straight or up he doesn't see anything double. So there is a intermittent transient diplopia. Next is asthenopic symptom. The patient, because of this diplopia and to compensate or to force his muscle to keep the image single, he will have more stress onto his rectus and vertical muscles, and to do in this bit an overuse of such what we say motor fusion, he will start having asthenopic symptoms and he will complain of frontal headache and other such complaints. Coming on to abnormal head posture, as we know, there is at least one gaze where there will be least amount of deviation. So depending upon in which type of or which pattern of squint it is, the patient will develop an abnormal head posture. So as I said, let's take an example that it is a V pattern exotropia. So in V pattern exotropia, deviation is maximum in up gaze. So what will happen, that the patient will raise the chin up. So the moment the patient will raise the chin up, eyes, because of Doll's phenomenon, will come on the down gaze, and because in the down gaze the position of your eyes will be in lower point, and the patient will have minimum amount of deviation. Or else, if let's say the patient has a V pattern esotropia, so he has a maximum amount of deviation in down gaze, so he will do a chin down. Okay, so the moment there is a chin down, the eyes will go in up gaze where there is a minimum amount of deviation, and because of which the patient will have less amount of asthenopia and diplopia. So these are the some of your notable observation which can be done. Coming on to next is abnormal retinal correspondence. So abnormal retinal correspondence means though there is a manifest deviation which is obviously seen, but the patient will tell you that he can see a single image. So basically it is your abnormal retinal correspondence which is acting, though there is a squint obviously seen, but still because of the fovea which has lost its retinomotor zero value, the other extrafoveal zone corresponds with it, and you can see a single image even with the presence of your manifest squint. Finally, there is also chances that there could be a strabismus amblyopia. Now, because both the foveas are not corresponding to one another, and if the patient is not able to develop the sensory adaptations and it keeps on having diplopia and other things, so what the brain will do, it will suppress one eye which is relating to more amount of your diplopia, and because of the suppression of one image, that could lead to something called as strabismic amblyopia, which is because of presence of squint. Clinical workup. So when we see this clinical workup, so in clinical workup what will happen, that you need to first of all see that actually is it a pattern of squint or is it just something else. So what Von Noden suggested, that if you want to do the amount of deviation to be checked at 33 centimeter, give a target to the patient and check exactly 25° up and 35° down. You just cannot randomly see at any gaze or any amount of angle. So he had a pretty conclusive evidence that doing this will give a better measurement and a better idea that is there actually a pattern present or is it something else. So what you ask is, you keep this stick right in front of the patient at 33 centimeter, ask him to look at this particular target and keep it in the primary position, check the amount of deviation, take it up 25° and take it down 35° from the primary position and check the measurement of deviation and see if there is an increase or decrease in any of the gazes corresponding to one particular pattern of squint. Also what you can do is you can do a version test which is simple to do, and you need not to have your fancy instrument or other a particular amount of angles and everything, and you can just see roughly that if there is exactly any pattern corresponding. So if you see here, we can find out that when the patient is looking in primary position, there is exotropia which increases slightly on up gaze, and in down gaze also it is increasing. So also with this you can say there is a pattern present. So this is how you generally do a version test. Compensatory head posture, as I already explained you, that just by looking at the head posture you can understand that where exactly the amount of deviation is more. So always the chin up or chin down is generally the compensatory head posture seen in your pattern of squint. So whichever side the head is being taken, so let's say if the chin is down, that means the eyes are went upward, so upward there is the least amount of deviation. Okay, so if you see upward there is a least amount of deviation, then you only need to check if there is an esotropia or exotropia. So if say it is an esotropia, that means it is a V pattern esotropia, that's why up gaze there is least amount of deviation. Or else if it is an exotropia, it will be a pattern of exotropia, because in A pattern exotropia it is having least amount of deviation in up direction. So in this, if you see example which is right in front of us, the patient has a V pattern of exotropia. So because the moment the patient takes his chin down, he looks from the up gaze, which is this, and because of the up gaze, what has happened, there is least amount of deviation and the patient can still see a single image. One thing which is very important to understand when you assess such patient is to check the binocular vision in the reading position, because we all know for distance he can still manage with different gazes, but for near, most of the time we see our work to be done at a near particular point. So the patients having a binocular vision at near point is very important. Our main goal for treatment should be to give him a better visual perception at a near point. So always check for a binocular vision at near point. So if there is good presence of your binocular vision at near, that is a good prognosis for you and the patient will have lesser problem. Finally, coming on to the treatment part. So surgical treatment is generally which is done. So if you see this diagram which is right in front of you, this generally shows the which muscle to be done for the surgery. So it is basically when you do a V pattern or an A pattern squint surgery, so that is the amount of transposition which should be done. So medial rectus muscles are always moved towards the direction of your vertical gaze where convergence is greater. So if you do a surgery of your medial rectus, so if you see this amount of your squint, so what you are generally doing is take the muscle towards the more converged part, or either take the lateral rectus away rather to the deviated, move towards the direction of your vertical gaze, that is your divergence. So what you do, you simply remember the mnemonic of male. Okay, so medial rectus apex, lateral rectus empty space. Empty space means away. So what you do is you generally do the surgery of your medial and lateral rectus muscle. So other options which you can be done, so for treatment of V esotropia, when we say, so what you can do is a bimedial rectus recession. You can loosen the both the medial rectus, or either what you can do is you can do a correction of V pattern with the inferior oblique muscle weakening when it is an overacting, or either the infra placement of your medial recti, or infra placement of medial recti with supra placement of LR. So as this suggests this diagram, so if it is a V pattern, what you will do, you can take the medial rectus muscle slightly from the original insertion point towards the downwards, or either you can take the lateral rectus muscle slightly upwards. That is how generally V pattern are treated. Vice versa for A pattern. So what you do is, for A pattern treatment, you can do the supra placement, like you cut the MR from its original insertion point, take it slightly higher and place it again, or either you can downward placement of your lateral rectus. So these are the some of the surgical treatment plan which are generally seen, or either you can do weakening procedures onto the inferior or superior oblique, whichever is overacting in whichever condition. So that is one of the point which can be done. So with this we end up with treatments. Thank you for your kind attention and your patient listening. I hope you understood what is your different pattern of squints and its different attributes and how to measure it. Please subscribe our channel for further videos on squint and binocular vision and other topics of optometry. Thank you and goodbye.